Good evening. Thank you for taking time to come here today. Some of you know me. My name is Dr. Attanti, and I've been working here at Citrus Memorial Hospital and with the Citrus Cardiology for the last 10 years. It's my 11th year. For the past 10 years, I've been here in this community working with the Citrus Cardiology. I'm a cardiologist and an intervention cardiologist, and we specialize in all cardiac problems and also specialize in the angiograms, heart catheterizations, and also the peripheral angiogram and the treatment of the peripheral angiogram. So today the topic is the PAD, peripheral arterial disease, which is a very common problem. I'm sure you or your family, loved ones have some heart trouble or any vascular problems. And I'll just go over, this is one section of the vascular problem. So vascular disease or plaque buildup in the arteries is a diffuse process, means it's all the arteries are one organ. They behave as one unit. Whether the leg arteries or heart arteries or the carotid artery, they all work as one unit. So the risk factors that I'm going to talk to you about, what causes these blockages in the leg arteries, PAD, I will go over them, and they pertain similar to the heart disease as well, and stroke, most of the strokes as well. So peripheral disease is very common, and it is the incidence goes up with age. It's higher if they smoke, or if the smokers, if the people smoke, they get much earlier in age, almost 20-25 years before non-smokers get this problem. Another problem is, the more common thing is diabetes. Patients with diabetes have very high incidence of PAD as well. So it is a common condition, but a lot of people are not aware of it. The awareness has increased recently, last 10 years, and even the physicians, the healthcare professionals are more aware now than before, but we still have a lot more work to do for the healthcare individuals and as well as the public education. This is part of that program. Thank you for all coming here today. And I thank for the sponsoring, Joey here for helping us with the food. And peripheral disease is the blockages or plaque buildup in the arteries of the legs mainly. What is the importance of the PAD? Because we want to prevent the amputation of losing a part of our body, a leg or foot. If there's a lack of circulation, the oxygen supply to the foot is diminished and people develop ulcerations in the foot, and they fail to heal when there's no oxygen supply there. And there's no blood supply there, there's no, even you take the antibiotic, it's not reaching the point where it's needed, where the infection is. So it's very important to see that, make sure the blood flow gets there for the ulcerations or the wounds to heal. So that's a typical wound. You see that in the first picture, and the result is the plaque buildup in the artery that blocks, gradually grows, this plaque builds up in the artery. If it is a sudden occlusion, then you will see symptoms, sudden onset of symptoms. If it is a slow occlusion over months and years, the body grows new arteries, smaller collateral arteries around it, and you don't see a sudden onset of symptoms until you get into trouble like an ulcer, a wound, a cut, and then it doesn't heal. Then you go to the podiatrist or the surgeons and they check the circulation. Then they find out that you have blockages. But there are other ways of finding out even before you get to the point of where you have an ulcer or a wound there in the legs. What causes them? What are the predictors? What are the risk factors that cause? Mainly high blood pressure. People who have high blood pressure, arteries are being exposed to the high pressure. They're prone to develop more plaque buildup in the arteries. Smoking, as I mentioned, is #1 cause of this problem. If you had smoked in the past also, you have a higher risk. Even if you quit, it's delayed, but you still have risk of having the blockage developing. Diabetes, I mentioned, especially if it is not controlled well. If the diabetes is not controlled, the plaque buildup is very fast in these patients. Cholesterol is another problem. A very high cholesterol patient with high cholesterol not treated will also give a problem. What are the clues we can get to risk? How do we identify these patients? How do we identify? If somebody had a problem in other territory, for example the heart, the likelihood of them developing a PAD is high. Somebody who had a stroke, they have plaque buildup in the carotid arteries, they have a high risk of having problem with the heart and the legs. So we need to screen for the patients who have heart trouble for the PAD and vice versa as well. Some of the patients present to us with PAD, they're not known to have any other problems before. That may be the first presentation of the arterial disease. They come to us and we check their legs, take care of the legs. Also we check the heart and the carotids on these patients. So it's a whole picture of the whole body of the patient we need to take care of. So especially in women, it's under-recognized. So is the heart disease in women, because the symptoms are not classical in women. We tend to miss or delay the diagnosis in women. So that's very true, and it happens every day. And we still fail to diagnose them, even though we are more aware, because their presentation, their symptoms are different from men. So we are recommending more healthcare professionals to screen and look for it. Simple things, like the symptoms of pain when you walk, when you're exerting. If you're able to walk 2 miles 6 months ago, now you're not able to walk to half a mile distance, then it comes down to quarter mile distance, progressively getting worse. That is a very important sign and symptom of peripheral artery disease. So how common is this? The reason we need to recognize this peripheral artery disease is it's one of the 5 top reasons for 5-year mortality on these patients is very high. So PAD is in the middle there, number 5. Heart attack patients, survival rate. If we follow 100 people with the PAD, if they're not treated, 30% of them are not alive at 5 years. And if they have a critical limb ischemia, means lack of circulation that causing the leg to lose or foot to lose or toe, it has to be removed. Those patients have even high mortality. Almost 67 of them are not alive at 5 years. So it's very important to recognize it and treat it and modify the risk factors. That's the key to success of the combined treatment for this problem. So awareness is very low. As I told you, the stroke awareness is almost 74%. Heart attacks, the awareness is almost like 67%. PAD is only 26% of people know aware of peripheral artery disease. So people don't know that it's not well known, not well recognized problem. So a lot of these problems come way too late to us. By the time they get to us, very late. So it's very important to be aware of possibility. Once we have a problem in one arterial system, it's important to keep awareness about the peripheral arterial disease. So this is the survey that with Medicare data they took. This was people who had amputations. Less than 50% of people had any vascular studies done. They didn't even have an ultrasound on the leg arteries. They just went ahead and did the amputation on this patient. Recognize the arterial problem. If you opened up the arteries, they would have saved to a less amount of amputation. They could have saved the limb, or at least it could have reduced the amputation to a toe or a foot instead of the whole limb. So only half of people had an angiogram or ultrasound to recognize the arterial problem in this patient. So it's very low awareness. Yeah. So once we became aware, doing an angiograms, so in the beginning, in the 90s, the treatment is bypass surgery from the femoral artery to the popliteal artery behind the knee. They used to do bypass surgery to the leg artery blockage. That is a very intense surgery, a high risk surgery. Now we've got less invasive, less surgical outpatient procedures now. We do it in the hospitals where the patient can go home same day. It's like a heart catheterization. Puncture, needle puncture, and then into the artery and go to the legs, take pictures and remove the plaque and balloon angioplasty or stent if needed. Majority of these patients are treated that way now. So if you see the graph, the green has never existed, not even existed in 90s. In 2000s, so half of what the surgeries did. Now the surgeries in 2010, way less. More procedures are treated, more of this disease treated with balloon angioplasty or stent placement. Less amount of surgeries are done now. So when you see the yellow box is the one, the amount of amputations, number of amputations. See, with the surgeries came down, with interventions came down, 2010, much lower. So more physicians are doing less, so which can be prevented on these patients. So what are the treatment options here we're talking about? Treatment options are number 1, number 2 to 10, lifestyle change. Once you have a blockage in the artery, by putting a stent, opening the artery, doing surgery, we're not curing anything there. We are only doing opening the artery, which is a temporary patch work. But if whatever the process caused the blockage continues, we haven't stopped any process of plaque buildup. What changes the plaque buildup is your lifestyle. If you have a blockage and you take treatment in any region, whether it be carotid arteries or the leg arteries, if they do not change the lifestyle, your dietary habits, your exercise habits, the process still continues. Very important, because the treatment, even if I put a stent, I want it to be successful. I don't want the patient to come back to me with a recurrent problem. The way to prevent it is to change in lifestyle. Very, very important. Dietary change, blood pressure control, cholesterol control, medication for cholesterol, and blood sugar control in diabetics, weight reduction, regular exercise. And if you do not change your diet, you're not going to lose weight. So if you do not lose weight, it's going to continue the process again. So all the treatments, all the medications, all the procedures, surgeries, they're all in addition to change in lifestyle. So if one point you want to take home today is, have I done any lifestyle changes since you're diagnosed to have a vascular problem? Ask yourself, have you changed anything? Because it makes a big difference. For example, I'll tell you an example on a patient who had a bypass surgery. I'm sure some of you had bypass surgeries here. So if person who changes the lifestyle, the bypasses can last up to 20-25 years. I've had patients who up to 35 years had a bypass. They're still doing well. compared to a person who does not change their habits, does not quit smoking, doesn't change their habit, doesn't exercise, their chance of blocking the bypasses are less than 5 years. Big difference. Big difference. So very important point to understand the change in lifestyle and dietary habits. Medications, of course, cholesterol, blood pressure medicine, diabetes medications, very important to take. And third one is the next, if those two don't work, medication don't work, your lifestyle change don't work, next is the last procedure is the surgical procedures, angioplasty, stenting, or atherectomy. We call them atherectomy, to remove some of the plaque. We have different devices to do that, different techniques to do it. So, but bottom line is that by all doing the procedure, we are only treating the point of problem at that time, at that location. But you have to treat all the arterial system. That one happens only if you change your lifestyle and control your risk factors. So this is some of the examples, some of the type of problems we get into, some of the blockages which are there, some of the different types of plaque buildup, or some of the soft plaques which are easy to open and easy to balloon angioplasty. Some of them are harder plaques. They have a lot of calcium deposition in the arteries. Calcium deposition comes when the plaque heals. Plaque builds up in the artery, and they also heal. Body tries to heal these plaques, so they become calcified, hardened arteries. Some of these are very difficult to open. Even if I open them, balloon angioplasty, they collapse back. So there are different techniques that we do to remove some of these plaques, break up this calcium, so that the balloon can expand, stents can expand, so that they stay open longer. So if there's a calcium hardened blocking, this is all the decreased chance of ballooning expanding the balloon, and decreased chance that stent can be expanded. That results in more problems down the line. So this is the cost analysis of the peripheral artery disease. So amputation costs, annual cost for the nursing home, all these things can cost up to annual cost for $75,000 to $100,000 per person per year. Very expensive. This is a device, one of the devices I use more commonly than others, called orbital atherectomy. Orbital means around the artery. It spins at a very high speed, 80,000 RPMs, 120,000 RPMs, and breaks these calcified plaque, hard plaques, into tiny pieces, smaller than blood cells, and they go through the system and excrete it. So some of this plaque removed, and it loosens the plaque so that balloon can be easily expanded. Some of it is taken out and grinded out into tiny pieces, and then we go back and balloon angioplasty after that, and if required, then we'll put a stent also there afterwards. This is into the small pieces. They goes into tiny, see the white blood cells, or white blood cells? The yellow ones are the particulates that are broken into the smaller than your red blood cells, very tiny pieces. Because the tip of this device, where it spins, has a tiny diamonds started on it. So it breaks them into very tiny pieces with the friction and high speed. This is one of the examples. You see the blockage on the left side, narrowing. Black and thick is normal. So the left side, you see the blockage, the two blockages, two spots where there is narrowing. But in between also, you see a minor length of blockage. So once you have a severe blockage in one spot, all the arteries will have some plaque buildup already. And they do tend to progress. We don't need to of them unless they're more than 70-80% blockage and you symptomatically. So if you don't do the atherectomy, the orbital atherectomy, the chance of plaque collapsing again is higher after the balloon. So that's what it says. This side is both lesions, one with the atherectomy, one without atherectomy. There's a big difference. This is one of the pictures. Patient came with a wound in the toe, almost like gangrenous toe. Usually if you don't do the angiogram, they would just go and amputate the toe. It doesn't heal. They go further up, amputate the foot, then the leg. But if you do the angiogram, you see there is a blockage there, and open it up, a month later, completely healed ulcer. No need for amputation. They prevented amputation to the patient. You see the blockage where it's circled? And then the tiny arteries growing around it, we call collateral circulation. But they're enough to sustain the limb circulation. But when you need, demand is more, if there's an infection, you need more blood flow. To exercise, you need blood flow. More blood flow is not getting more flow with a blockage there. So other metabolic disorders that can cause to this heart blockage are advanced age, renal failure, kidney failure patients, somebody who's a kidney dysfunction, the calcium is not being excreted well, and the patient analysis, they have very hard arteries, calcium in their arteries. They become very hard to open the arteries. That's where this device helps to grind this plaque down. So what is early screening for peripheral disease? Anybody who is above 50 years of age, or be aware of it. Current or past smokers, kidney disease, high blood pressure, high cholesterol, symptoms of leg pain, fatigue, tiredness. A lot of these symptoms also could be from arthritis. So a lot of people think, hey, I'm getting old, arthritis kicking in, so they think something else. They never think about the PAD. I've seen patients going through back surgeries, hip replacements, because they do have some arthritis. They go through hip replacement, still the hip is there, still the leg pain is not gone. Then they look into the arteries later on. When they open the artery, hip pain is gone. Okay. So it's very important to check all the system possibility of causing these pains. And toe or feet may look pale, one may be worse than others, or one may be colder than other leg, one cold feels more colder than the other foot. That also will help. Soreness, wounds that are not healing as fast as they used to in the past, and also the nail growth, hair growth. You lose the hair on the leg, and you're not growing back, and the nails are not growing that fast, they're dropping, and they're not growing that fast as to before. In the past, you used to cut them like 2 weeks. Now 2 months ago, they're not growing fast. That's another indication that there's a possibility of peripheral artery disease there. Any questions?
Yes. You mentioned about the high-speed guiding dip. Is that exclusive down the leg arteries? And the reason I ask is there's been a lot of work on my heart, and I've never heard that mentioned until, is that just exclusively the legs?
The question is, the atherectomy device, orbital atherectomy, is only in the legs or is it in the heart as well? The FDA just approved the device for the heart. We do have another device called rotablation, rotational atherectomy for the heart. We have had it for 20 years. We use that. But recently, just 5 months ago, we got approval by the FDA, this rotational atherectomy for the heart. Yes, that's a very good question. Anything else? So what tests can be done to do the PAD, to detect for PAD? Number one is very simple, called ankle brachial indices. They do it in the office. Any doctors, most of the primary doctors do it in their office, or cardiologists. They do it in their office. Simple blood pressure cuffs they put in the legs and arms and check the pressure difference. They know if the pressure difference is low. Other tests are ultrasounds, some tissue oxygen supply, they need little oxygen meters they can put on the feet and see if there's a difference. Number 3 is if they can have ultrasound or the CAT scan, MRAs of the leg arteries. They're all further testing. Once you have symptoms, then the first screening test with ABI or ultrasound, and then CAT scan, and then angiogram and treatment. That's a process. A lot of people also should make use of the screening tests that come, life screening. They come in the truck to the church and all that. They charge you like $100 for 5 tests. I think we should make use of that. Everybody should get, they check for the aneurysm, they check for the carotid artery disease, they check for PAD. The life screening, they come once in 3-4 months, they come around, they schedule, they give you an advertisement in the newspapers in the local churches or hospitals. Should you make use of that? That's a very easy one to do, and they do a pretty good job. Once they have any abnormality on the test, take that report to your doctor, then they will further investigate. Yes, sir.
I had a stent put behind my knee about 15, 20 years ago. How long has that? They said it was good for about 10 years, but it's never bothered me.
The question is, if they had a stent 10 years ago, how long does the stent last? If the stent open, whenever there's a stent put in, the body reacts to the injury that you caused in the plaque. You're disturbing normal plaque morphology there. Your balloon angioplasty, your atherectomy putting a stent there, your body reacts and blocks inside with the scar tissue. The scar tissue forms in the first 4 to 6 months. If the stent is open at 1 year, it's open for good. Unless you develop another blockage before or after that. That's again. Once you need a stent is put in a place where the blockage is worse. The other areas will not be normal. Generally what happens is 5 years later, 10 years later, they come back, there's another blockage in another area. The stent looks fine, but there's a blockage in other areas. That's where the importance of changing lifestyle comes into effect. Yes, sir.
Won't some medicines cause you to lose hair on your arms and legs?
The question is, can some medications cause to lose the hair? Yes, they can. Sure. Most medications they'll mention there, and then, there are 200 different side effects they list on most medications. Sure, there can be. Any new medication causing it, stop it and see if it resolves. And that's the only way to know. Yes, sir.
You said something about back pain and leg pain. If your doctor suggests that you have to have a hip replacement, are you supposed to say, well, why don't you check the artery first before they do something like that? Is it up to me to do that?
The question is, if somebody recommended hip replacement, should they check the circulation? Yes, they should check the circulation.
Are you with your doctor?
Doctors can easily detect, or a nurse can easily feel the pulse in the feet. If you have a good pulse in the feet, that means there's not a severe blockage higher up. If I can feel a pulse in the foot, that means there is no severe blockage higher up. So simple examination will tell us by feeling the pulse there. If you do not have the pulse, next step will be to check the ultrasound and then the CAT scan or angiogram. Yes, ma'am.
Where is the best area to check the pulse in the foot?
In the foot, in front of the foot, just on top or behind the ankle. Right here behind the bone, you can feel the posterior tibial artery, or in the front of the foot, right in the front, you can feel the pulse too. Just like the radial pulse, you can feel the pulse in the foot. When you go home, take off your shoes, you can check it, you'll feel the pulse. That's the best way to do. You ask your spouse, to check the pulse. You can easily feel. Don't press too hard on it. Just light pressure, you can feel it. Yes. Yes, ma'am. The question of pulse rate I'm talking about, that relates to your heart rate. It doesn't mean We're talking about pulse, amount of pulse. Is it weak or strong? Not the number of beats we're talking here. Yes, sir.
One more question.
Sure.
You talked about us being fat and lazy. So,
Say that again. Say that again. I didn't hear that. I didn't get that.
I said we're fat and lazy.
Lazy.
That's why we have PAD.
Okay.
What I was wondering is, some people have artery disease and they're not. So could that be genetic? Is that you never mentioned whether it could be
Okay.
hereditary or anything like that?
That's a very good question. Question is, why everybody who's fat is not getting PAD? Am I right?
Yeah, that's pretty good.
That's what it is, bottom line, right? Not everybody who's fat has a PAD. That's true. The PAD does have some genetic effect, yes. But majority of the genetic effect are related to your habits that you learn in your family. Bad dietary habits from the family. You know, you have 5 brothers in the home, and all 5 brothers are used to same cooking. That's what you like, that's what you grew up with. So they all have the similar diseases a little sooner, earlier, later. Some of it is genetic, and most of it is the habits that you get from home when you're growing up. That's difficult to change, but if we can change the habits, the results are extremely good. That will help in addition to what treatments we offer. Whatever we do, if you don't do your part, the failure rate is high. All bad news here, right? Yes.
I've been in the hospital multiple times, and each time that they go and they check for the pulse down below, and if they don't feel it or they don't sense it, they put a device on and tip the toes. And nobody seems to worry. I guess it must be something because my legs haven't fallen off. But nobody says anything. It's like it's good, bad, or indifferent. Is that a common occurrence? And this has been for over a bunch of years.
No, they put the oxygen probe there because they couldn't feel the pulse? You don't know what No, it's nothing specific to it. It's simple. I can check your pulse at the end of this talk.
But they can't feel it, but yet they put a device on here and that's okay?
Yes, that's okay. That's okay. They'll see the waveform on the pulse oximeter, and if it's a good waveform, means there's a good pulse there. Oxygen supply is good there. But still, feeling the pulse is important. Ask one of the nurses or your doctor or your spouse to feel the pulse there. You can easily check it. Any other questions? Yes, ma'am.
Dr. Attanti, if you could please just mention the importance of walking, not only to prevent PAD, but once you have PAD, to stop it from getting worse. The heart patient. So like the thing to do.
Right. The reason, one of the reasons, the PAD is the lack of blood supply there. We open the artery, and if there is no demand, you're not exercising, you're not looking for demand there, there's no flow there. The reason, most reasons to bypasses to close or the stents to close is lack of demand in the territory. If there's no need there, there's no flow required, there's no fast flow going through, it'll shrink. It'll clot. Blood clots on the vein grafts. So typically the reason the bypasses fail is that when the artery bypass attached to an artery, further down 2 years, 5 years later, there's more blockage in the same artery after the bypass attached. So there's not much flow going through that artery, which is again plaque build up continues in the further down. So when there's no flow down the artery, the bypasses will not stay open. Same thing with the PAD again. Exercise is very important to continue afterwards. Not just the heart, for the legs and the carotids and everything. Very important to change again the lifestyle. Whatever you did so far was not correct, right? That's why you got a problem. So if you don't change from there, you got a problem still there, hasn't gone. You know, so that's the key. Otherwise, we do the surgery, we do the stent, we don't need to see you again, right? We can say bye bye, go to your primary doctor. Why do you see the cardiologist? Why do you do the surgeon afterwards? To prevent, to change your habits, to change your lifestyle. That's the key. It's hard to do, it's not easy. But the person who does it will see the difference. Weight reduction, not just for the heart. Your knees will feel better, your back is better, you enjoy life better. All right. Any other questions? Now the question is, if they have a venous problem, you have pain in the legs? Yes, you can. Yes, because they retain fluid in the leg, they get heavier. That could be arthritis too. Multiple problems can be there. Sometimes we treat the arteries, maybe open the artery, put a stent or surgery, and then the pain is still there. So what else can cause pain in the legs? Not all pain symptoms are from the artery blockages. Most common one is arthritis. Number 2 is sciatic pain. Pinched nerve in the back is very common cause of the leg pains. It can have same symptoms as arterial blockage. So the differentiation is that you get a good pulse there and you still have this pain to walk. That means it could be some problem with the back, pinched nerve, or disc, prolapsed disc or something like that, or spinal stenosis, something like that. You need to further work up. So these are 3 major common problems. Fourth one is the neuropathy. Diabetic neuropathy can also cause pain in the legs. So these are the 4 main reasons. This one can be corrected easily. The arthritis is difficult to correct completely. Pinched nerve to some extent they can correct, but it's also a difficult problem to correct. Neuropathy is even more difficult to treat. At least circulation wise, sometimes when you open the arteries, neuropathy improves. Some of the neuropathies, because of lack of blood supply, results into neuropathy. So when you open the artery, if some permanent damage is done, it's too late to improve. But a lot of times it improves neuropathy when you open the artery blockages. Yes, ma'am. Okay, question: any restless legs is a symptom of heart PAD? It can be, but it's totally entirely different pathology behind it. But sometimes with the PAD symptoms, the patient comes to the office with PAD, with the restless leg syndrome. Some of it improves after the treatment with PAD, but it could be 2 different problems there as well. Any other questions? Thank you. You got the questionnaire, all of you. If any of those questionnaires are problematic, please give it to us and contact your doctor or physicians. Show it to them that, hey, this is a screening test we got and we have these symptoms. Should I need to go further testing? We'll be glad to take care of you with us, but if you have a doctor, please see your doctor with the symptoms. They'll be able to tell them.
Will be on our website, citruscardiology.org.
Okay. So this video will also be, if your friends and family want to listen, and this will be on our website, citruscardiology.org, and you have educational videos on the left bottom with a number of videos there with the talks we give. We try to load them on the website. It takes you to the YouTube and it plays the videos there. Please make use of them. All right. Thank you again. Thank you for coming.